Hello, and welcome to a video about nasogastric and nasoenteric tubes at Yale New Haven Hospital. My name is Will Cushing, and I am one of the physician assistants on the hospitalist service here at Yale New Haven. More importantly, today I'm one of the members of the procedural team here at the hospital. And our goal for today is to provide some background information about nasogastric and nasoenteric tubes. We will then move on to discuss some of the techniques and resources we have at our disposal for placing these tubes. And then we'll end today with a case that highlights some of the issues that can come up if these tubes are not placed correctly. So we're going to start by going over some of the indications for a nasogastric or nasoenteric tube. As you can see, there are a variety of indications and reasons why we place these tubes. When people have a bowel obstruction and need to be decompressed, we often have to place one of these tubes to decompress them and also improve their symptoms. Similar reasons for placing the tube when someone has an ileus. And then there's other reasons why we may choose a different type of tube for medication or nutrition. So some of the confusion that is out there around these tubes is that you can place a large bore nasogastric tube and really address all of the indications on this screen, where the smaller bore nasoenteric tubes are really most used for medication administration and for enteral nutrition. And during the rest of the talk, we're going to go through some of the differences between these tubes. On this slide, I have highlighted some of the different types of tubes and would like to just go over some of the nomenclature, because this can be one of the confusing parts of being on the wards in the hospital, is a lot of people will refer to things using brand names versus types of tubes, and I just wanted to clear up some of that nomenclature that we use in the hospital. So as you can see, we have nasogastric and we have nasoenteric tubes. The nasogastric tubes are the picture in the lower left, and that is actually a Salem Sump tube, which has two lumens in it, one to take fluid out and another lumen to take air out. A Levine tube is not used too commonly, and that's a single lumen large bore tube. So when most people refer to a nasogastric tube, they are referring to the Salem Sump tube that's seen in the picture on the left. The nasoenteric tubes come in a variety of flavors. There are Cortrak tubes, and there are KO feed tubes. They are both made by the same company. The KO feed tube is the middle picture here. And then we have Daub-off tubes at some hospitals. That Daub-off tube is pictured on the right side of the screen. And we have not had Daub-off tubes at Yale New Haven Hospital for quite a while. They're made by Covidien, and we have migrated over to just using Cortrak tubes. So just to summarize, if you're talking about a nasogastric tube, it's usually going to be the Salem Sump tube. And at Yale New Haven, if you're talking about a nasoenteric or a small bore tube, it's going to be the Cortrak tube. And we're going to spend quite a bit of time talking about those later. This picture here of a nasogastric Salem Sump tube is taken right off of one of our units, and if you have a patient who needs to be decompressed from a bowel obstruction or an ileus, or you are having to take fluid out of the stomach, this is the large bore nasogastric tube that you would be using for that indication. On this slide, I am showing you the two different types of Cortrak tubes that we have. The Cortrak tubes come in two different sizes. The first one on the left is gastric, and it has a blue tip to the tube, and the second size is a jejunal tube that has a brown tip. The main difference between these two types of tubes is that the jejunal size is about 30 centimeters longer, and the lumen is a little bit wider, because when we're feeding people distal in the GI tract and post-pyloric, these tubes tend to be better for those patients. Going back to our indications for a large bore nasogastric tube, here is an Xray of someone who clearly has a bowel obstruction, and the right choice of tube for this patient is that large bore nasogastric tube, which is going to allow you to have 2 lumens to take that fluid out of the stomach. This is a patient who, if you had placed one of the smaller bore Cortrak tubes, it wouldn't really help the patient out because those tubes are just meant to be putting medications and nutrition into the patient. Going back to the nasoenteric tubes and the gastric and jejunal tubes, I've summarized on this slide some of the reasons why you would choose a gastric versus a post-pyloric tube. Gastric tubes should usually be our first choice. There's a variety of physiologic reasons why it's best to feed patients directly into the stomach. These tubes are relatively easy to place, and because the stomach can distend better than a portion of the small bowel, we can often give larger volume feeds to patients. So most patients are going to be a candidate for a nasogastric Cortrak tube at the beginning. Some patients on the right of the slide, though, do meet the criteria to have a post-pyloric tube placed, and we most commonly think of patients who are aspirating despite having a gastric tube, or they might have gastric dysmotility, delayed gastric emptying. In some patients with really severe pancreatitis, we may need to feed distal to a fistula or some other abnormality in their GI tract. So these are patients who we may be using a post-pyloric tube for. In all types of nasogastric and nasoenteric tubes, there are some insertion complications that we need to be aware of. Listed here are some of the ones that are somewhat minor, as far as some patients just have a really hard time tolerating the procedure. Other patients, by having the tube in, will get a sore throat. It's possible to cause a nosebleed when you're placing the tube. And then there are some more serious complications. In the lower left of the screen, you can see the kind of dreaded picture of placing a nasogastric tube and getting into the central nervous system. This is pretty rare in the internal medicine realm, but it is a good idea to always be talking to patients about prior surgeries they have had. I was once called a couple years ago to place an NG tube on a patient who had just had a transphenoidal pituitary biopsy done at an outside hospital, and that procedure was done 72 hours before I was called to place the tube. So we had to have a discussion with the team and all the consultants following that patient about the other options we would have instead of trying to place a tube where there was a communication with the central nervous system. On the right side of the screen, you see the other dreaded complication of this procedure is a pneumothorax. And you can see a pulmonary placed tube in the Xray and then a sizable pneumothorax in the cross-section of a CT scan down below. So we're fortunately today going to talk about some of the ways that we can avoid that complication. When placing nasoenteric tubes, and specifically the Cortrak tubes, we are fortunate here at Yale New Haven Hospital to have Cortrak assistance and a guidance system. So as you can see here in the pictorial on the screen, this is a graphic representation of the path of a nasoenteric tube being placed. And this is kind of an ideal placement. The tube goes in through the nose. It goes down vertically through the esophagus into the stomach, along the greater curvature of the stomach, and then this tube is placed into the beginning of the small intestine. So I'm going to talk to you a little bit more about how this machine works and how to set it up so you have that information when you have to place these tubes at the bedside. This slide is a picture of the Cortrak imaging guidance machine. This is an electromagnet that allows us to see where the tip of the tube is during the insertion of the Cortrak tube. You can see the various components of that on the screen here, and all of those components are put on a stand that you would wheel to the bedside to use while placing the tube. This is just another reminder of the components of that. There is a transmitting stylet that's physically in the tube while you're placing it. There is a device that goes onto the patient's stomach and chest that relays that information back to the screen, and then the display unit is there as well. And we're going to talk a bit more about the tracings on that display unit. This slide shows what is the preferred view of a tube being placed through the nose and into the esophagus. You'll commonly hear people talk about a vertical drop, And on the right side of the screen here, you see that straight vertical drop down to really the intersection of the X and the Y axis. And that's what you want to see when your tube is going in. If this tube was to have changed course earlier and you didn't see the vertical drop, you would be concerned about it being placed in the lung. But for this representation, we're seeing this tube go straight down, and right now is at right around the GE junction in this picture. Once you've successfully navigated the esophagus and go through the GE junction, then you will start to see your tube make what is called a reverse C as it goes around the greater curvature of the stomach. And you can see that on the avatar picture here, as well as you can see that reverse C in yellow on the view of the Cortrak machine. So if you were just placing a gastric tube, this would be a sufficient tracing to stop. And in most patients, you would be somewhere between 60 and 80 centimeters in when you see this picture on the patient, and this would be a perfectly well-placed gastric tube in a patient. As we discussed earlier, there are some patients where you're going to want to feed them more distal in the GI tract. I find this picture helpful because you are navigating this tube at the level of the nose. And this picture of the gastric anatomy and then an endoscopic picture of the pylorus, I think helps to give people some background that it's actually pretty tricky to be able to thread the Cortrak tube through the pylorus. It often takes multiple attempts of moving the tube in that direction before it will actually go through the pylorus. And sometimes it's just a matter of patience and getting these tubes placed correctly. As you can see on this screen, when the tube does navigate through the pylorus, it then starts to go into the small intestine. And in this picture, the tube is crossing through the pylorus into the first section of the duodenum. You can see that as it starts to move into the small bowel, the depth cross-section on the display unit starts to show you dropping and the tube is going retroperitoneal. That is another mechanism that helps us confirm placement and where we want our tube to be. This is just another graphic representation of that ideal placement of a tube that has very good vertical drop. It has the reverse C as it goes through the stomach, then it pops through the pylorus, and you start to see the depth cross-section drop as your tube goes retroperitoneal. And then going back over to the right anterior view, you can see your tube coursing along the small intestine. Here's another X-ray image just showing that anatomy of the pylorus and the beginning of the small bowel. And this X-ray is a really nicely placed tube that has been able to successfully navigate the pylorus and has gone distal enough in the small bowel where we'll be able to feed this patient safely. Here is an X-ray, unfortunately, of someone who did not have a very good vertical drop on their Cortrak tracing, and you can see the pulmonary placement of the nasoenteric tube into the right main stem bronchus on this X-ray. A patient who does not have that appropriate vertical drop will have a tracing that looks like one of the three displayed on the screen here. These are all Cortrak images taken from our hospital, and these are patients where the tube was inserted, and instead of having that vertical drop that brings the tracing all the way down to the X and Y axis, this tube either bifurcates to the right or to the left, and unfortunately that's a signal that you are in the lung. Now, when you pick that up early, usually somewhere between 30 and 40 centimeters, then you're able to stop progressing the tube and pull back and start the procedure or reevaluate if this is going to be a safe patient to place the tube on. But it's really critical that we're able to identify these Cortrak images and know when our tube is not in the right spot. So with that background, I'd like to share a case that was only a few years old from the British Medical Journal. And this case involved an 83-year-old patient who had underlying inflammatory bowel disease. She was seen and admitted to the hospital and had a colonoscopy performed. And unfortunately, this colonoscopy showed that the patient had sigmoid stenosis, which prompted them to do a therapeutic procedure. After that procedure, the patient showed signs of clinical deterioration. As you can see in here, she was tachycardic, she had a fever and an acute abdomen, her lactate was elevated, and there were signs of hypoperfusion of her bowel. She underwent a procedure to repair that area of her bowel, or resect with having a subtotal colectomy, because it revealed that she unfortunately had a rupture of her cecum, and she was admitted to the ICU after that. While in the ICU and after being extubated, the patient had a post-pyloric feeding tube placed because she was not able to eat by mouth. This placement was difficult in this case, and they mention here that it took multiple attempts to place the tube. And then a few hours after having the tube, she again showed signs of clinical deterioration. In this case, she was showing signs of respiratory failure, and a chest X-ray showed that the placement of the tube was in the lungs, not into the stomach. This next X-ray shows that tube coursing down a little bit vertically, but then you can see on this X-ray that the tube diverts out to the right, and really gets pretty distal into the airway on the right side in this X-ray. To provide more context, this is the actual Cortrak image of that tube placement. And there's a couple problems with this tracing. One, the tracing isn't midline right from the get-go. So this is somebody who I would have adjusted the placement of the Cortrak unit to make sure that we were seeing the right tracing that we wanted to see. But even with that shift to the left, you can see that the tube comes down straight initially, but then makes that diversion out into the right main stem and below. And unfortunately, in this case, this wasn't picked up during the insertion of the tube. So unfortunately, due to the misplaced tube and the lack of recognizing where this nasoenteric tube was, this patient developed a aspiration-induced lung injury. Initially, it was complicated by necrosis of the right lower lobe and an empyema, and they started by trying to just drain this. In the meantime, they found out that they needed to treat the patient with both antifungals and antibiotics, and that, unfortunately for her, wasn't enough. Here is a CT image of that patient, and you can see the pigtail catheter that was in that area of an empyema. And as I alluded to, this did not resolve the situation for the patient. Unfortunately for this patient, despite the efforts with treating her with antibiotics and antifungals, and despite the pigtail catheter, she didn't respond to treatment. And ultimately, she needed to have a lobectomy done, which is a pretty severe response to a tube that was misplaced, and something that definitely was preventable. At the time of publishing the article, the patient had recovered, but she did that after needing 4 months of care in the ICU, which could have definitely been shortened had she not had this iatrogenic event. So to summarize some of the learning points from this case, there is definitely a best practice for placing these nasoenteric tubes, and that is to use the electromagnetic guidance of the Cortrak machine to hopefully be able to interpret the initial placement of that tube and avoid a complication, either a pneumothorax or in this case the abscess and empyema that developed. We should always be using a chest X-ray, even after using electromagnetic guidance for placing these tubes, and when we catch these early, we can avoid some of the catastrophic complications that can occur. So to summarize our talk in general, I wanted to go back to the difference between large bore and small bore enteral feeding tubes. The large bore gastric tubes are used for patients who need to be decompressed from a small bowel obstruction, or they may need to have a lavage performed. The smaller bore enteral feeding tubes can come in two types. They can be gastric or they can be post-pyloric. All of these Cortrak or enteral feeding tubes should be placed with guidance and then following that guidance with radiographic confirmation. Most patients who have the smaller bore Cortrak feeding tubes can be started on a trial of gastric feeding, and in many patients that will be sufficient. In some patients who are critically ill and have other indications for a post-pyloric tube, then we can either convert a gastric tube to be post-pyloric, or right from the beginning we can place that tube initially past the pylorus. One last note about both types of tubes is they are both meant to be short-term solutions. Neither a nasogastric tube nor a nasoenteric tube are meant to be placed in a patient for longer than days to weeks. So if you're concerned that it is going to be a long-term issue for the patient, then we should be having that discussion as a care team and with the patient and their family about long-term solutions. So I hope that this information has been helpful. I know that there is some confusion about nasogastric and nasoenteric tubes on the floors, and I hope that this video has been able to clear some of that up. If you do have questions about patients who have these tubes, or you have a patient who needs to have a nasogastric or a nasoenteric tube placed, and you're uncomfortable with any aspects of that, you can always feel free to call the hospitalist procedure team, and we would be happy to come help you with that patient.